Hi, everybody. I'm Director of Strategy at California Institute for Behavioral Health Solutions, and I am so excited to introduce our presenters today. You are in for quite a treat with this webinar. We have three different speakers. We have Dr. GLORIA MORROW, we have Dr. RITCHIE RUBIO, and we have Maria Rea. So Dr. GLORIA MORROW is one of the nation's leading clinical psychologists, and she devoted her early career to teaching students in undergraduate and graduate psychology programs. As an academician, a clinician, and an author, her teaching, counseling, and books have helped thousands of people find true inner healing. She's the Director of Behavioral Health for Unicare Community Health Center, and she's presented the results of her research at professional conferences all over the world, including Cape Town, South Africa. As a top-rated professional with profound insight in her trade, Dr. GLORIA's work has been published in scholarly journals and books. She's been cited in critically acclaimed national publications such as Psychology Today, Jet, Heart and Soul, Essence, Women's Day, and Black Enterprise. She also, in the incredible amount of spare time that she has authored several books, and she's just finished writing a stage play. She also completed a first draft for a feature film. She's a sought-after keynote speaker and seminar workshop facilitator and has expertise in many topics, including depression, anxiety, marriage and relationship issues, and a variety of issues relative to people of color from all ethnic backgrounds. She has become well known throughout the faith community because of her willingness to address the issue of mental illness in the church and the role of pastors and church leaders in granting permission for parishioners to seek mental health services outside the church when appropriate. Dr. GLORIA is a master trainer for the California Brief Multicultural Competency Scale training program, and she's helped to develop that training curriculum. This program focuses on 4 major ethnic groups: African American, Asian Pacific Islanders, Hispanic, Latinx, Mexican Americans, and American Indian Native Americans. She holds a PhD in clinical psychology from Fielding Graduate University, Santa Barbara, and a Master's of Science in Marriage and Family Therapy from Azusa Pacific University. So that is Dr. GLORIA. Dr. RITCHIE RUBIO has worked as a clinical child psychologist, play and expressive arts therapist, researcher, storyteller, program evaluator, statistical consultant, data analyst, telehealth consultant, and associate professor and lecturer in a variety of clinical and academic settings. And this includes public health systems, universities, pediatric hospitals, community and mental health settings, schools, and research institutes. He's worked in 3 different countries: the Philippines, the USA, and New Zealand. He moved from the Philippines at the age of 25 and completed his PhD in clinical psychology with a child and family emphasis. He graduated from the California School of Professional Psychology through a Ford Foundation International Fellowship Program. His clinical work was and still is primarily with immigrant and multicultural children and youth and their families. He mostly integrates psychodynamic attachment, family systems, multicultural and expressive arts, play therapy, and cognitive behavioral therapy orientation. As for research interests, he explores global gender roles, therapy strategies that blend Eastern and Western paradigms, cultural specific worldviews, and diversity initiatives. He's a staunch supporter of evidence-based and deliberate clinical practice, and his work has been published in peer-reviewed journals, and he's presented his work at the APA and AFTA conferences. Dr. Rubio is currently the Director of Practice Improvement and Analytics of Children, Youth, and Families System of Care, the Behavioral Health Services, and it's in the San Francisco Department of Public Health. In that role, he plans and coordinates a clinical practice improvement and research or evaluation program focused on identifying best trauma-informed and diversity-responsive practices. That is Dr. Rubio. And then Maria Rea is a licensed marriage and family therapist. She's the Outreach and Engagement Coordinator for Behavioral Health and Recovery Services at the County of Marin Department of Health and Human Services. She's been helping support the department's efforts to reduce ethnic and racial disparities. She's by investing more resources, training, and support for community health advocate and promotora programs in underserved communities. This is a focus on Latinx individuals, monolingual Asian populations, and individuals that are living in Marin City. She also focuses on increasing coordination and cultivating relationships with grassroots, faith-based, and other community providers and partners. Prior to this position, Maria was the evidence-based practices lead and fostered strong relationships with key community partners and BHRS staff. She also serves as the co-lead for the BHRS LGBTQ+ work group, and she was previously a therapist at an inpatient facility providing services for people with dual diagnoses. She's trained and worked in a variety of clinical settings and provided psychotherapy to adults, adolescents, children, couples, and families, with a focus on addressing the needs and disparities in the immigrant Latinx population and the LGBTQ+ communities. All right, so I told you, you have great presenters today, and now I'm going to go ahead and turn this over to Dr. MORROW to start.
Good morning, and thank you so much, Jennifer, for the wonderful introduction. And I just want to take a moment, you know, words have power. And initially, some of the words we used to be described or for us to describe ourselves, we may not have understood fully the implication of those words. So she referred to me as a master trainer. I'm changing that right here and now. And I'll just say that I'm a lead trainer for the CBMCS because we want to make sure we're sensitive to the words we're using because they could be offensive and have different meanings that we don't want them to have for us in our conversation or for our lives. So thank you so much for having me. And I want to take a moment to also say, I know we're going through a really interesting season right now. And there may be a lot of stress and a lot of panic and a lot of anxiety that we are feeling. And even those of us who work with others to help them during this time. So I just want to remind you to take time for yourselves and to exercise self-care and to be mindful. I know it's very interesting that we are dealing with telehealth and doing things that we haven't done before. So our plates are really full. So I want to acknowledge that today and encourage you to be sure to take good care of yourselves in this season. So next slide. So as you all know, we are experiencing probably two of the greatest pandemics of our time, one COVID-19 and the other racism. And they are contributing to people's need to have mental and behavioral health services from every ethnic and racial background. But I want you to remember that people of color have really been hardest hit because of COVID-19, because of a lot of health disparities and a lot of other challenges communities of color have. So they're dying at higher rates. And we know that this is really devastating. And also with the recent overt acts of racism can also be contributing to their trauma, and they may even be re-traumatized, which makes it very important for mental health services to be available. Racism is increasingly being recognized as a public health issue. And so it's very critical that we are able to not only utilize our platforms on telehealth, but also to provide culturally responsive behavioral telehealth services so that people will be able to benefit from those services. Next slide, please. I want to talk to you a moment about the trauma of racism, and I know that this is not directly related to our conversation about telehealth, but it is related to telehealth because people may want to discuss what they are going through right now. So I just want you to understand how traumatizing racism is. It is considered a fundamental cause of adverse health outcomes for racial and ethnic minorities and racial ethnic inequities in health. Which may experience why communities of color are being hit hardest. And then the experience of individual, institutional, and cultural racism has been found to be uniquely predictive of post-traumatic stress syndromes and symptoms. And then racial trauma can involve a negative, sudden, and uncontrollable experience or crisis. And so there can be this ongoing physical or psychological threat that can produce feelings of fear, anxiety, and depression, helplessness, and even PTSD. And then when people of color are bombarded by acts of aggression and microaggressions. This is not only examples of interpersonal trauma, but also the trauma of racism, which is then examined through the lens of intergenerational trauma, which then makes people feel re-traumatized over and over again. So we have to understand that racism in America and even throughout the world is not good for anyone's health. And so when people are coming to see you now, because this conversation has been heightened, so they may want to talk about their feelings of being discriminated against or feeling that they have experienced racism. Next slide. So telehealth has been traditionally used in rural communities, and they decided to use telehealth because some folks couldn't even get to a mental or a physical health provider in their communities. And so we have to understand that it is not universally used across the US because there are some concerns about infrastructure, privacy, and even crisis management. And so it also brings about some unique challenges regarding safety issues. And I just remember a week ago, I had a client call in, and the client was in serious distress. And so I had my first opportunity of calling a crisis team and getting help for someone virtually. And that was very anxiety provoking to me because I couldn't have that person wait in my office. That person could have jumped off the phone at any time or jumped off that video camera at any time and said, I'm ending this conversation and thus going to end my life. And so I was just having a hard time dealing with the fact that I'm trying to coordinate all of these things virtually. But thankfully, I was able to get that patient to stay on the call. We were able to get help, and then the crisis team called me back to let me know they were at the home. And so my fears were allayed, but that's not going to always be the case. So this is one of the unique challenges. And then telehealth is now a popular tool due to COVID-19. In fact, there are special, considerations now for telehealth worldwide because of COVID-19. Next slide, please. So there are a couple of studies, not a lot, that kind of demonstrate that telehealth is effective for diagnosis and assessment across many populations, and even populations of color, and for disorders in many settings, and it appears to be comparable to in-person care. And I can say this, that, in mental health, we have a pretty high no-show rate, unless you're in private practice. But if you're working in a community health center or in community mental health, you will see a lot of no-shows. But with telehealth, we have seen a reduction of our no-show rate. And so that's been very, very promising. And also we have found in the research that telemental health care can provide effective and adaptable solutions to the care of mental illnesses universally. And when we compare it to in-person services, we find that it can be advantageous and inexpensive through the use of current technology and adaptable designs, especially in isolated communities. And also right now with COVID-19, we're seeing that this is a very good solution for us. Next slide. However, with every good thing, we can find barriers. And so one of the things that I wanted to focus on as I talk about these barriers is the real need for us to continue to practice culturally responsive and utilize the tool of cultural humility. It's still lacking. And so if you haven't done your work around those areas with dealing with people in person, you certainly haven't had time to jump into that now that we're on, telehealth platforms. So that is a serious barrier. Also, mental health disparities continue to exist. We know that people of color are less likely to receive effective mental health services than those in the dominant culture. That has not changed. Has it improved? Yes, but we still have a lot of work to do. Also, the people we see, our communities of color, still have some help-seeking attitudes. They still have stigma associated with mental illness. They have beliefs and behaviors that are sometimes negative about even reaching out for mental health services. And then there can be a distrust for this unfamiliar system we're talking about called telehealth. And what I am also learning is that people that have been with you when you were seeing them in person are much more likely to be okay with telehealth than those who are coming in brand new. And this is their first experience with a therapist or a mental health provider. And now they're seeing you virtually, and that's not always comfortable. So sometimes I'll have people come on and say, I'm going to turn my camera off. I don't want to be seen. And that goes to the next barrier, which can be environmental factors, because they don't have those lovely ways to have virtual backgrounds like some of us do when we're speaking virtually. So we're seeing their homes, and to them, their homes may not be the way they would like them to be. So that can serve as a barrier. Also, they may not have special spaces, to have privacy. So I have been on a call with a client and seen family members walk by. I even saw a patient, and I've shared this with my team who are presenting today. The person didn't have on all their clothes, because they aren't accustomed to doing this thing virtually. So environmental factors are certainly sometimes a barrier. And then accessibility to relevant technology. Everybody doesn't have a smartphone. And I hear people all the time who say, I don't have a camera on my phone. So we're having to do many more phone sessions than video sessions because sometimes they don't have internet access and they don't have the availability to have a camera. And then, as I mentioned earlier, crisis and suicide risk can also be a serious barrier because we aren't there with the patient or client at that time. And then sometimes therapists are not totally equipped because they haven't been trained in behavioral telehealth. They don't know how to operate their system properly, or they don't feel comfortable being in a virtual space. And then the last barrier, of course, is going to always be there. There are a shortage of therapists. And because many more people are accessing telehealth right now, because of all the stress and strain that they're under, they may have to wait longer periods of time to get help. Next slide. So I want to leave you with some strategies for improving behavioral telehealth for communities of color. So we're going to have to do a better job in our systems of care to provide technological resources and assistance to communities of color. I think we have to start asking the questions, what do you need in order for this to be effective? And we have to do a better job of reaching out to patients and clients to let them know that we are resources for them to help this to be a successful transition for them from in-person to virtual. And then we need more training. There needs to be more culture responsive and humility training to providers to help us all to understand the cultural world of communities of color, and then to become more comfortable discussing issues such as racism virtually. For some of us, it's difficult to discuss it in person. And you've got to ask yourself this question: why is it so uncomfortable for me? And I think you have to do your work as well as to be willing to have those courageous conversations, especially right now, because people are in trouble. They are feeling a lot of stress and strain because of the racial climate in America. And so we have to be okay to talk about that without devaluing the person's experiences. Oh, it's so easy to say, I'm wondering if this is unhealthy cultural paranoia. And when we do that, we devalue the person's experience. So we have to be more comfortable in having these courageous conversations and providing a safe space for people to feel like they can say what they need to say in order to get better. And then there needs to be more training on telehealth. Most of us were kind of thrown into it with maybe a day to prepare because of COVID-19. We didn't have a chance to really go through and even to decide which was the best telehealth platform for us. I know at home, I do a little bit of my practice at home, and I use doxy.me. And I love it. It's so simple. You send your client an email invitation with the link, and they click on the link, and then we're good to go. But for some agencies, they don't have that system. So we are dealing with different systems. And so we need more training and to learn how to use evidence-based practices and even community-based practices for treating communities of color. I'm afraid that sometimes we're just doing check-ins because we're not comfortable using the system. So we're not really working with goals and objectives and using our techniques that we use, traditionally when we are face to face with a patient or client. So we still need to do those things. They still need to have the experience of a therapy session with us virtually. So that means we have to become more comfortable in doing that. And then there should be a team approach in helping people of color to feel connected. If you already have a patient or client that you've been seeing, like I said, it's much easier, but this is the time to ask them, how are you enjoying or not enjoying telehealth? And that gives you an opportunity to fix some things that need to be fixed. But you may need to spend a lot more time in community building and trust building with the new people who are coming in because they're only going to see you on a screen. And for some people, they don't trust that because they have already experienced a lot of reasons why they should not trust a system that has traditionally been oppressive. So thank you so much. I think that's my last slide. Would you turn to the next one? I think that's it for me for today. Thank you so much. And I'll be around for questions should you have any. Thank you.
Thank you so much, Dr. Morrow. And now we're going to turn it over to Dr. Rubio.
Hi, good morning, everyone. Thank you, Jen, and also thank you, Dr. Gloria, for that wonderful opening, really, for this last of the series for our webinar. And again, thank you to CIBHS for sponsoring this. I think for many providers, I couldn't speak for everybody, but this really has been like a really great holding environment for many providers, especially during this time where we had to shift a lot of our practices into purely telehealth platforms. So my section, I'm naming it like Walk the Talk. And as I'm talking more about what are things that we could do as providers, I would also really strengthen the whole idea of like, how do we walk this talk, like when we are working with communities of color. Next slide, please. So I just want to acknowledge that this month we are celebrating for July BIPOC, or Black, Indigenous, People of Color Mental Health Month, which originally was called like National Minority Mental Health Month, but there was a lot of push, especially in the past 2 months, to really come up with a name that is more inclusive and strength-based, and that really de-emphasizes the power differential between minority and majority, given that there's a lot of stigma and at the same time like negative labels attached to minority, like being inferior. So it's more appropriate to really think about this celebration for this month as a celebration for Black, Indigenous, and people of color. Next slide, please. I want to start where I come from in terms of data stories because that's part of my work. So in San Francisco, and this was a small study that was only done for like 7 civil service clinics, we tried to find out exactly like what are the population that we are serving. And the story here in this data really speaks to, in these 7 clinics, they serve primarily Latinx, Black, African American, and Asian clients. And part of our goal really in making sure we strengthen our work is to make sure that our workforce also mirrors the population that we serve. Of course, this is a moving target. It changes through time, especially in public health with staff turnover. But then we try our best to really try to create like a workforce wherein it mirrors our population. But it seems there's still a lot of limitations. Like if you see there towards the right, like for every for the Latinx population, there is one provider who is Latinx who serves like 16 Latinx clients, 1 to 17 clients in the Black or African community, and then 1 provider to 10 clients in the Asian American community. So you see here, there's a clear gap in terms of that cultural match. But what's the importance of having a cultural match? So next slide, please. Here's another data story of qualitative study I did with Ana Rodriguez Martinez. And this really went into a clinic that serves primarily Spanish speaking clients. And it focused on Latinx unaccompanied immigrant youth. And with this, with clinicians who meet with them who are also Latinx, the importance of having cultural match really strengthened the whole idea of being able to more adaptively use or integrate cultural values in the work, like personalismo or being personable, like really sharing your personal stories with the client as a way to really increase or improve their engagement. So you see here that, and this would be shared to you later on too, is that cultural match could be very important, especially in increasing or strengthening engagement and also decreasing like dropout among clients. Next slide, please. Now, if you look at the research, like around like cultural match, is it really that important? And it's true, especially for people of color, like Latinx and African Americans, generally prefer to be matched with their clinicians or their providers. And it really decreases dropout rates, and it also improves like access and engagement, especially in the beginning of treatment. But then, through many meta-analyses or studies throughout the past years, there is little evidence that therapeutic outcomes improve as a result of racial or ethnic matching. And there were even studies that really talked about a strong decline over time in benefits of ethnic or racial matching. Of course, there's always the importance of cultural match when we think about working with people of color or communities of color, but it's not enough. What then should we do? Next slide, please. I think for every clinician or provider that works with communities of color, it's good to first anchor yourself in terms of the evidence base. What is the evidence base out there in terms of how certain interventions work with certain populations? Looking at the research, also digging deeper into your own clinical experience or your expertise as a clinician or a provider. But the most important part of that evidence-based practice model is to looking at the client perspective, like the context of your client, especially if they are from a community of color. And how to approach that context or individual context of your client is really respecting and being sensitive and aware of their cultural background. Culture, of course, being different levels of diversity, whether it's race or ethnicity, sexual or gender orientation, religious or spiritual affiliation, and many other different levels of diversity. And the way to approach it throughout the past years was really a strengthening of different ways to approach it: cultural awareness and sensitivity, cultural competency, and cultural humility. For me, at least, I feel that it needs to be a good balance of these three, wherein being culturally competent is really about looking at interventions, whether there's any research out there or there are ways by which we use deliberate practice to culturally adapt our interventions to meet the needs of our clients who are from communities of color, but at the same time to respect or integrate their cultural values in what we do. But at the same time, there's also cultural humility. I think when I first entered graduate school, not so long ago, like there was a lot of push around cultural competence that you have to know how to have evidence-based practices on how to work with certain populations. And later on, there was a shift in terms of, because of the diversity of communities of color, it's hard to be truly competent in working with every single one of them. And there's now a stance, a growing stance of cultural humility, wherein you approach clients of color with more a stance of curiosity, like asking them to walk you through their cultural values and find ways to integrate that in what you do. And then with cultural competency, of course, there's also culturally adopted research base out there, which I think for every clinician should look out for as a way to integrate it in their own practice. And according to Bernal, there are many different ways by which we could integrate cultural values or cultural elements in what the work we do, looking at language, looking at goals, looking at cultural concepts or paradigms of thought, looking at metaphors. I think like for me as a clinician, metaphors is very important. I'll give the example of like working with Filipino clients. Like many of the Filipino clients I've worked with come to me saying that they are burdened by their problems. It's like a heavy load on their back. And that's like a perfect metaphor for many Filipino clients. And so there was this clinician named Decentiseo who came up with a burden bearing model for Filipino clients, or a pagdadala model. And really, you could integrate this metaphor of burden bearing into current practices that is evidence based, like CBT, like thinking about the burden in terms of what are your thoughts around that burden? Is it something you cannot escape? Is it something that you could not manage or reorganize to lighten the burden? Or you could use like mindfulness activities as a way to soothe yourself to be able to more lightly carry that load behind you. So there are various ways by which we could integrate evidence-based practices into like cultural metaphors such as burden bearing or pagdadala. And of course, there's the added side right now, integrating culturally adapted interventions with telehealth. And I think this is a big gap in the field right now. And I'm sure after this pandemic, or once this has passed, the pandemic of COVID-19, there will be more research really integrating how to use culturally adapted interventions with via like telehealth platforms. But right now, there's a dearth, and really the call for us as clinicians is really to do our own deliberate practice. We are all new to this, and really we have to carve time to really find and really think, how does this intervention work if I'm using a video conference? What if my client who doesn't have access to Wi-Fi because of the access or engagement issues around like a video conferencing? What if they only have a phone? How do I use my interventions just via the phone? So a lot of things to consider and to be flexibly working around, culturally adapting our practices with telehealth. Next slide, please. And thank you, Dr. Gloria, for really naming another pandemic that we are grappling with, which is really racism and the racial trauma that is bringing to a lot of our communities of color. And this brings me back to in San Francisco, we have a very strong data reflection process wherein we look at our data outcomes based on the CANs, which are many of you are very familiar with in California. And we look at from a systems level and a program level, also an individual level, like looking at the CANs outcomes and looking at what are the reasons why kids and youth are improving through time, and what are the reasons why they are not improving through time. To that last question, it has been consistent for the past 3 years that one reason why, especially with communities of color, they are not improving as expected in their outcomes through time, it's because of ongoing trauma. Compared to a diagnosis of PTSD, where we think about like a single traumatic event, most communities of color go through ongoing trauma in their communities. And so that in itself becomes a barrier in terms of like improving in their outcomes. So really with racial trauma, it has been named in many different ways depending on the community of color we are trying to address. But then it has a similar vein of really raising like traumatic stress reactions. Racial trauma can be overt, something that you experience yourself, you become victim of a traumatic experience. It could be vicarious, like hearing or watching videos of George Floyd can be very traumatic from a vicarious standpoint for many communities of color. Or it could be very covert, something unintentional and has little effect, but then it can still raise like racial trauma, like when we think of like microaggressions. And of course, the unconscious process too of racial trauma and how it occurs in many communities of color when we speak about intergenerational transmission of trauma, like Dr. DeGroote talked about like post-traumatic slave syndrome, or like with Latinx communities from the healing ethno and racial trauma framework, they talk about racial trauma in terms of the immigration story, or the consistent or persistent oppression of laws and policies in the US for Latinx communities really contribute to this racial trauma. Or when we think about like Native American cultures, like First Nation histories of genocide that has been transmitted intergenerationally too, across multiple generations. Or when we think about like the experience of Japanese Americans, the intergenerational transmission of that stance of silence around the experience in Japanese internment camps during World War II. This is all different stories from different communities of color, but they fall into that experience of racial trauma. Next slide, please. So beyond cultural competence and humility, therefore, there is really a need to be also trauma informed. And if I would push it further, we have to be racially trauma informed in the way we work with communities of color. And, we can draw from many different fields around this. And for me, the one that really sits well with me and the one that I have effectively used for communities of color is using the 3Rs model, like finding different interventions that really follow the pathway of the brain. I work with kids, and sometimes, I teach them about the brain. And one thing I use is, for example, the brain model, wherein I use like a glove. I'm not sure if folks can see it, but then it's a brain, and really to show them that when one is dysregulated, the tendency is that one gets stuck in their brainstem, especially if we just talk about like trauma experiences. One gets stuck in their brainstem as if they were still in that trauma experiences of having a flight, fright, or even like a freeze response. And also they become emotionally dysregulated. Therefore, the limbic system of the brain is activated. And there you talk about like anger, like rage, or like sadness. So in having those brain parts activated, it's harder to access the higher cortical functions. So it's harder to talk about the trauma. It's harder to talk about the anger. Therefore, as a clinician, we have to slow down or scale back in our approaches. I mean, Dr. Gloria talked about like checking in, and that's typical too in many providers I've worked with, that there's nothing to talk about during sessions. I mean, I check in virtually and we end up like we're done in like 10 minutes. And really thinking about, are there other things that we could do aside from accessing the cortical functions, aside from talking with the client, wherein we help the client really regulate and relate to activate and also calm down their limbic system or their emotional brain so that it becomes easier later on to really access or talk about the trauma or racial trauma or anything else that is distressing for a client. Next slide, please. So in terms of regulating, I think ultimately our presence and attunement as a clinician is our best tool for really helping a client regulate. But when we're doing like telehealth, integrating like multiple breaks, having like movement activities, helping your client go outside in a safe way, having breathing exercises or mindfulness. But it's also important to, there are many mindfulness or progressive relaxation exercises out there, but then they are not really culturally affirming or culturally responsive. Or listening to like a meditation exercise for like a person of color, but then the one who's reading the prompt of the meditation is a white person. It may not be as effective sometimes with certain clients. It's good to look around, again, through deliberate practice, look around for different mindfulness activities that can be culturally responsive. For example, Dr. Candice Nicole came up with Black Lives Matter meditations. Or Argos Gonzalez came up with mindfulness of injustice, a mindfulness exercise for Latinx communities. Or there's an app that you could use and share with your clients via telehealth called Liberate Meditation. And in this Liberate Meditation app, this app actually has very meditation exercises that could speak to liberating ourselves from, for example, internalized racism, or restitching is one meditation uh, prompt there, where it talks about healing from displacement trauma. So in using that, it could be more really reaffirming of the experience of a client and responsive to their needs that way. And also, like when we use like progressive muscle relaxation, I was looking at, like trauma focused CBT that have been validated in many different cultures, like using exercises to emphasize, for example, the difference between tension and relaxation. Like usually the prompt is, you can imagine yourself as like a cooked noodle versus an uncooked noodle. And in Zambia, for example, when they try to validate this, they use, instead of noodles, they use okra, because okra is something that many of the families can relate to. Or in Spanish-speaking families, they use like fideo or tortilla as a way to make this distinction. So there are ways by which we could culturally adapt different practices from evidence-based interventions that we use. Next slide, please. To relate with a client is really being attuned or sensitive to conversations or to your relationship with them, validating or empathizing with their disclosures of racism or racial injustices is part of relating. And with telehealth, preparing your virtual space, making it consistent for your client, maybe become very important. And how you put objects behind you as a telehealth therapist. Like if you're a play therapist, making sure that you have play materials that are culturally affirming. If you're looking using like miniatures, like making sure they represent a diversity of families or communities of color can be very affirming for clients. And also, in relating, since it really activates the limbic system of the brain, using non-verbal, non-language based platforms like expressive arts. Through telehealth, if you are doing a video conference platform, you could use like a whiteboard as a way to facilitate art therapy with a client. Or you could do like Sandray therapy, even virtually with a client. I was in webinar 3, and in there I showed, for example, like with Sandray therapy, you could have your own Sandray, for example, and then you become the hand for the client for them to pick like miniatures and then create stories in the sand that way. Or If you want it to be really purely virtual, wherein your client can really use it themselves, you could look at, for example, the virtual Santry app, which they could use. I mean, it's virtual, the objects are virtual, but then it's a way for a client to do virtually like a Santry expressive story. Next slide, please. Appealing to reason, of course, this is more what we are familiar with, like talk therapy or insight-oriented therapies. Or when you're using expressive arts, the prompt after wherein you ask your clients about, can you walk me through what's going on in your story and what you drew or you expressed through art, or in your Santry story? That becomes like a narrative which is verbal based, which is really appealing to the reasoning part of the brain. Use of worksheets. Sometimes if you're using like CBT, using telehealth, you can share worksheets. But then when you work with communities of color, worksheets have been, for example, translated. Some of them have been translated. Make sure to use those because some of them may resonate better with clients. Or the use of apps. A lot of apps out there, for example, may not necessarily apply immediately or engage like communities of color. But there is slow growth of like apps out there which are specific to communities of color. One I can name off is the Safe Place. So in the Safe Place, there's really an app that was really designed for Black or African American communities, helping them with self-care tips in coping with, for example, police brutality, having mental health resources in the Black community, and also like assessment processes that have been validated with Black or African American communities. So looking at Safe Place. And if you're using an app through telehealth, you could actually mirror the app from your phone so your client can see it from their end. And that's one way to do it. Digital storytelling is another one, and you could use like different apps. Again, these are resources I put towards the end. You could access it, and together with a client, you can collaboratively have them or facilitate a conversation around the racial trauma. Next slide, please. So in the title of my section, I talked about it as walking the talk or to walk the talk. The talk is really about race and ethnic socialization. We're having race conversations, not only with our clients, but also with our peers. And also really encouraging, for example, caregivers or parents that you work with to start race conversations with their children. And there's a lot of resources out there, like Embrace Race is really a wonderful website. It gives tip sheets and webinars on how to hold race conversations with everyone, and especially with children and youth, and how best to support this that is safe and very strength based for clients or for children and youth. And Dr. Rihanna Anderson, for example, came up with Embrace. And Embrace is really engaging, managing, and bonding through race. And this was a wonderful intervention which really emphasizes the need for race and ethnic socialization, which comes in two adaptive ways. One is helping clients develop or strengthen their cultural pride or racial pride, be proud of their roots, be proud of who they are. And at the same time, the second part of this intervention is really helping the clients develop some coping skills on how they would address like bias, on how they would confront or challenge like discrimination when they encounter it in their communities or with people like in school or their workplace or with anybody else they are in a relationship with. And so those are the two parts of this. And through telehealth, there are various ways by which we could hold race and ethnic socialization practices or race conversations. For kids that I work with, I use like bibliotherapy. And there are many books out there that you could share screen. And right now, if you're exploring through YouTube, a lot of books around like social justice or like race, like even for kids, have been read by the authors themselves, and that's something you could share to your clients with via telehealth. Two that I would point out too. One is something happened in our town. So this one is a story about uh, a victim of police brutality, a Black or African American person, and how two families, one white and one Black, had conversations about that incident. And later on, how the parents or the caregivers facilitated conversations around what can you do even as a child to really challenge like racial injustices in your own community, like in school or with your friends. Or most recently, like Ibram Kendi came up with anti-racist baby. And the recommendation for this is it's really for ages 3 months to 3 years. And let's go to the next slide, please. Like a lot of caregivers often ask me, like in my work, like, should I shelter or protect my kids from talking about race? Like there's a taboo element to it. Like we should protect our kids from having these very difficult, challenging conversations. When in fact, it's very good to start early, even as early as 3 months, because that's a time that beginning, like kids have an awareness of race differences. And we can start early, like with board books, having like race conversations, like being aware of like differences. According to Tatum, race conversations can give children a helpful frame for understanding difficult realities. If parents are silent, children will draw their own often faulty conclusions about it. Next slide, please. So, really, beyond the talk, beyond having race conversations or promoting race or ethnic socialization, there's really the walk of what it's not enough just to talk about it. The walk for me is really about addressing what many communities of color go through, which is really racial trauma, and drawing from the field of trauma focused therapies to really facilitate those that healing for our clients. So in terms of like trauma narrative processing, I'll just give like a few examples of what I do in my work. Like for example, using journey sticks, which came from the Native American interventions around trauma, from honoring children, manning the circle by Bigfoot and Schmid. We're in really situating the trauma in the context of one's lifeline. And you could do this via telehealth. Just ask your client to, find a stick or a twig. And then on that stick, they would lay down like symbols that would represent good experiences in their life, as well as traumatic experiences in their life. It's a way not to isolate their story, because what I noticed from many trauma focused CBT, there is an overemphasis on the trauma story, as if it was one single event that you could isolate in time and help the person heal just with that one incident. But really, that trauma story is situated in a person's lifeline. And it's good to situate that way. Using journey sticks from the Native American or Aboriginal cultures could be one way. Using the Tree of Life narrative is another way by Oliver and Urich. Where in here you talk about the roots, talking about like mud to represent like trauma experiences or distressing experiences, or integrating like Latinx cuento therapy, wherein like using cuentos or folk tales from Spanish speaking countries as a way to strengthen like cognitive restructuring work or CBT work around like exposing oneself to the trauma narrative. Or one from Dr. Megan Corrado, she talked about like stories as a way to really help inner city youth, arrange or organize their story as a lifeline, and using expressive art as a way to also heal this inner city youth from racial trauma. Next slide, please. And lastly, one that I have used effectively as well, and I know this has good cultural validity across many different cultures in the world, is narrative exposure therapy, wherein this really builds on the theory of dual representation, wherein we focus on the traumatic experiences of a client, but then making sure that it is anchored in the lifeline stories of a client so that it doesn't really perpetuate like fragmentation. So, next slide, please. So, really, via telehealth, and I've used this via telehealth too, it's asking a client, for example, to construct a lifeline using just a thread. And in that thread, they use like pieces of flowers, either plastic or real, and then rocks. And then each flower would represent wonderful or positive experiences in their life from birth up to the present time. And then they use like stones or rocks to represent like distressing, sad, grief stricken, or even potentially traumatic experiences in their life. And they lay it out as a lifeline. So you could see you could do this via telehealth. And if you're using like the neurodevelopment pathway intervention, you can start by having a mindful walk with your client, if they're on their phone, where they go outside to pick like flowers and rocks. They come in, they engage in this activity non-verbally without you asking questions or prompts. So it becomes like a way of calming their limbic system and activating it, just engaging in that emotional experience of like reflecting on their life. Then later on, then you can appeal to reason by now asking the client to walk you through their lifeline. And then based on that, then you start processing or helping them heal through their trauma memories. So I would end there. And really, the last three slides, next slide, please, are really just resources. And this has been sent to you as handouts. So everything I've talked about here or reference, I put it there as a link with the exact resource where to find it. And hopefully it could strengthen your work. Thank you so much. And now I'm passing on to Maria.
Okay, thank you. I know we're changing the presentation right now, so let's hold on 1 second. I wanted to thank Dr. Gloria MORROW and Dr. RITCHIE Rubio. It is really a pleasure to be here today with you all. And I also want to thank CIBHS and Jennifer and Robin and everyone in the team that helped organize this important series of events. My presentation is going to be a little different from the amazing ones that we just had. Next slide, please. I will be talking about specifically about our transition in the County of Marin in behavioral health and recovery services, our transition to telehealth. I'll be sharing some of the strategies that we have used and what we have found so far. Next slide, please. I wanted to start this presentation by sharing some of the demographics from our county, as I believe this will set the tone for the rest of the presentation. As you can see on the chart to the left, 71% of our population identifies as white, 16% identifies as Hispanic Latinx, 6% as Asian, 3% as Black and African American, and 4% identifies as other. It is very clear with this chart that we're not the most diverse county in the Bay Area. And I also wanted to share some of the cases around COVID-19 in our county, because I believe this really shows the importance of having webinars like this and having conversations around supporting communities of colors at all levels, especially when we're talking about behavioral health and substance use services. If you can see the middle chart, 78% of our cases in this county are Latinos, Latinx, Hispanic, which, like Dr. Gloria MORROW shared earlier, were being disproportionately impacted by this virus. And if we looked at hospitalizations, 50% are Hispanic Latinx, 13% Asians, and 3% Black and African American. It really is a very high number. Next slide, please. In BHRS, we have several different programs. The point of entry to our system is the access team, which is composed of mostly bilingual clinicians. We have a children's system of care, we offer adult and older adult services, forensic mental health services, crisis stabilization unit, substance use services, and prevention and early intervention. Many of these services are contracted out to community-based organizations and individual providers, and we have all stepped up to providing some form of telehealth or flexible services and identifying unique ways to increase outreach and engagement. Next slide, please. So before COVID-19, BHRS provided less than 1% of our services through telehealth. And after the shelter-in-place order, we have moved to now providing 32% of our services through telehealth. And as you can see on this chart, however, 48% of our clients still prefer phone appointments. And like Dr. Gloria talked earlier, it could be that they don't have the necessary technology to be able to use telehealth, and that's why they prefer phone services. There could be a lot of reasons, but it's still the majority of our services are being provided through phone. Next slide, please. So like I shared, around 27 to 32% of our services are provided through telehealth and assessments, 48% of children's services, and 23% of adult services are also provided through telehealth. Next slide. And if we look at specifically at telehealth services by race, 56% of these services are for clients that identify as white, 26% for Hispanic Latinx, and 7% for Black and African Americans. Next slide, please. And I'm trying to go as fast as I can because I also want to give some time for questions, and I'm being mindful of the time. So if we look at the language that the services are being provided, 89% of these services are in English and only 8% in Spanish, and the number is even less for Vietnamese. When we looked at these charts, when we looked at these numbers in BHRS, we recognized that we really have a lot of more work to do to support communities of color. So I'm going to share with you some of the strategies that we have used so far. And I want to be very clear that this is the first time that we're really providing these kind of services to our communities. And we're learning as we go, and some of these strategies will change, and we'll be adding more of them as we continue learning in this process. Next slide, please. So far we have implemented telehealth throughout our system of care. We have given access to all our providers to implement telehealth services, while being also flexible and allowing the option of an in-person or field appointments when needed. We have also moved some of our services, especially psychiatry appointments, to a facility in the Canal District that is closer in proximity where most of our families live. We have implemented 3 telehealth kiosks for clients with no access to necessary technology, and the idea is to add 10 more throughout the county, being very mindful and strategic about where we're going to place these kiosks so we can target specific communities of color that don't have the access for these services. We have also started a series of support groups in collaboration with community partners. So for example, we started a parent conversation group with Marin County Office of Education, and we're providing these groups in Spanish and in English. And we have started also family support groups, and a Lean on Me community check-in series. These groups are open to everyone, and people do not have to do an intake or sign paperwork. They just have to register their email and they receive the link to be able to attend the meeting. This really facilitates attendance from everyone in the community. I can tell you that as an immigrant, even though I have all the privilege, private insurance, access to a lawyer if I need it, I still fear accessing mental health and physical health services, and worry that this might have some kind of consequence in my opportunities of living in this country, even though I have read, consulted, and I know this won't be the case. So being able to offer groups where people just show up virtually and don't have to go to a government building really helps certain immigrant communities feel safer and more included. We have also improved our outreach, because we noticed as we started doing these groups that no matter if we created 10 or 12 or more support groups for our communities, we were struggling with getting the word out, right? Because we weren't able to go to different places and share these resources. So we really had to improve outreach and engagement. And one of the strategies we used is we're sharing with our Spanish speakers through the radio show Cuerpo, Corazón, Comunidad, which sharing their resources, and this show airs live every Wednesday at 11 a.m. We also continue to increase collaboration with community partners and with other counties. For example, we partnered with Alameda County, San Francisco, the CDC Foundation, the Zuckerberg Initiative, and on creating a website mostly for youth, because we noticed at the beginning of the shelter-in-place order, the youth were being left out of the conversation about how challenging it is to actually have to stay at home all the time. So we wanted to create a page with resources, all kinds of resources, including mental health and substance use, and it also has a tab for parent resources. So I welcome you to visit it. It's called crushingthecurve.me. And we really want this to be a resource for youth all around the Bay Area. And we continue to update our existing BHRS website with resources, updates, and tools for community members. Next slide, please. So in preparing for this presentation, I was able to meet with some of our contracted providers, and I asked them what they're doing to support telehealth services for communities of color. And this is what some of them shared. So North Marine Community Services shared that they've started conducting a technology needs assessment, sometimes during the intake or before the intake, where they're asking clients if they have a phone, a tablet, or a computer, if they have Wi-Fi, or if they have internet through their phone, because they realized that when people had to use a program like Zoom or other different telehealth services, if they were using internet through their phone, it would be more expensive for clients, so it wouldn't really be an option for them. So really brainstorming with the client if the option would be to give them a hotspot or what other resources would they have. They also started asking clients if there was a young person at home that could teach them navigate technology. As we all know, youth this age are really savvy with technology, at least they know more than I do, and because also they're having to do school from home, so they're more familiar with these programs, and by asking a youth to help them, the people were having more easier access, right? I know in the Spanish group that I do, the parenting group that I do, one of the clients was really having a hard time logging into Zoom. So at the beginning, I was just calling him and he would listen, and then he was able to log in, but he couldn't really hear us, or we couldn't hear him. So we asked him if there was a young person, and then the young person was able to solve the problem, and now he's able to fully attend through Zoom. They have also started handing out flyers at food banks, testing sites, and grocery stores. And they realized that attachments through emails weren't accessible for everyone. So they started taking pictures of the flyers and writing a couple of sentences of a description of what the flyer was and sending them through text, as people are more familiar with this way of communicating. Canal Alliance has really increased their presence through social media. They started creating short videos about mental health and stigma. And I was able to talk with one of the therapists, and she shared that she's noticed a shift in her sessions where she's having to assume more a role of a case manager, or she's having to provide resources that are available in the community. And they continue to do trainings around public charge and COVID-19 to help immigrant communities really understand their rights through this pandemic. Community Action Marine has increased their hours in their WAM line. They are and they created a line specifically for Spanish speakers, and their calls have increased 33%. And Bacalus Suicide Prevention Hotline has increased their outreach, their trainings, and their support, and their calls have also increased 33%. Next slide, please. So what we have found out so far, what we've learned from this process and looking at, again, our charts, is that, like Dr. Gloria shared earlier, we have noticed a 20% decrease in no-shows across our system of care, which is really amazing. And I know also this number is going to change as people go back to work. We have also noticed a 13% increase in mobile crisis response services and a 22% increase in substance use outpatient and intensive outpatient services, and a 22% decrease in access assessments. So overall, this decrease in services comes from a result of less referrals. We're especially from school, because schools are closed, so we're receiving less referrals. And because of the less referrals that we're receiving, we're also doing less assessments. And also, some of our clinicians have been deployed to cover COVID response efforts. So as some of you know, when we work for the county, we are disaster service workers, which means we are required to support the county in situations like this. So I'll give you an example. The county created a COVID-19 call center for all community members to ask questions about everything COVID-19 related. And I'm currently working at that call center twice a week. And then the rest of the week, I do my normal job. Next slide, please. So what I think is the most important thing that we have found right now and that we keep noticing is and Dr. Ritchie and Dr. GLORIA already mentioned this, but it's really the need to do flexible and creative problem solving. When we're assessing for clients' technology needs, how are we going to support them? If they don't have a cell phone or internet, how are we going to help them? And if we think about telehealth, we hear a lot about the digital divide, but we also have to keep in mind the actual physical space. And when we're talking about communities where one family is living in the living room, the other family is living in the bedroom, where is a client's safe and private space to talk through to actually do a telehealth session. So as providers, we must think about all these logistics and come and have agreements with families, with our clients about how we're going to have our sessions. So could the family have an agreement that while mom is doing a telehealth session, could someone else be taking care of the kids, or what could happen, right? So we also have to think about confidentiality. For example, one of our clients didn't want their family to know that they were doing therapy sessions. So how could we brainstorm with that client to keep their confidentiality going through this hard time when the client is having to stay in the house with their family all day, right? So what strategies could we come up with? So could the client go for a walk to the park and have their session there? Or what could they do could they sit outside in the car? What strategies would be the most helpful without the client having to disclose to the family? And as I shared earlier, we have increased our access to other resources because we want to be mindful that some people might need other kinds of support, like the support groups that I mentioned or community building events. We're also mindfully providing more flexible service delivery, which is really asking providers to modify and challenge the structure of traditional therapy. So for example, instead of doing a 1-hour session weekly, maybe we can realize that it might be better for some clients to do a 30-minute session twice a week, or we could see that maybe bi-weekly would be better, really asking clients what is best for them during these challenging times. We might also, like Dr. Ritchie talked about, we might also realize that we need to change some of the goals during therapy during this stressful time. So we might create new short-term goals, like providing more resources and coping skills and harm reduction and stress reduction techniques, all of those resources that Dr. Ritchie shared. And it is really important that when we're problem solving with our clients, we provide solutions that are culturally responsive and proactively anticipate the needs of community and not assume that a one-size-fits-all model is going to work for everyone. We recognize that during this time, some people get their mental health needs met in other ways that could be more specific to each culture. And as providers, we need to acknowledge other healing practices that tend to be dismissed and are not celebrated. So if my client is practicing and using certain herbs like to help with stress or with anxiety, we should recommend that they consult with the doctor first, but not condemn these practices. What we're really wanting to accomplish by providing flexible and creative problem solving is really asking our clients, what are the things that keep them well within their culture, within their context, and within their environment? And next slide, I believe this is the last one. Here is my contact information. If you have any questions, feel free to email or call me. And that is it. I'm going to pass it again to Jennifer. Thank you so much.
Thank you, Maria. Thank you, Dr. Gloria. Thank you, Dr. Ritchie. If we can all come on screen so that we can have a little bit of discussion. This was amazing. I have gotten highest number of comments of just, thanking all of you. And we all know we need to go deeper. So I'm going to try to get to a few of these questions. I just do want to remind people we had a lot of questions come in. And we do take all these questions, we send them to our presenters, they answer them, they get posted to our website, and once it's posted, you'll get an email about that. So don't worry, if I don't get to your question, you will get an answer. So Dr. Gloria, I'm gonna pass this first question to you. Do you have any good ways to specifically learn about our clients' cultural experience? I often find clients saying, I don't have a culture, because their culture feels so normal in their life that they don't even identify it as part of their culture.
Such a great question. And so perhaps the first tip I would give is that we don't want to ask them to talk about their culture. I think one of the general questions that you can get that information from is to ask people to share, how they're doing right now. You want to ask them, with everything going on in the world, with both of these pandemics in operation, how are you managing everything? And then you'll get a lot of information that you would find interesting in trying to answer that question. And the other thing that I ask people especially after I have done some bonding with them, is to have them share their story. I say to people all the time, with everything that you've been through, every hurdle you've had to cross, you're still here. And please tell me what you have done to stay here, because I want to bottle it up and sell it because it's so powerful. And so that gives me a little bit about their resilience. It validates what they've been able to do to stay here and to still be functioning. It may not be what we would consider high functioning, but they are still here. And so I think you'll learn a lot about their culture, because sometimes they'll tell you about their faith. The reason I'm still here is I pray, I go to church, I meditate, I chant, I do all kinds of things. So now that's a part of their culture that they're telling you about. Or I stay with my community, and my community means everything to me. I work in my community. And then, that's a part of their culture. And so just some of those kind of general questions can be helpful.
Excellent answer. Thank you so much.
Thank you.
I'm going to move on to one other question. Dr. Ritchie, we had one participant who was hoping that you could briefly explain post-traumatic slave syndrome.
Okay. Thank you for that question. And really, for post-traumatic slave syndrome, I would refer you to the wonderful, amazing work of Dr. Joy DeGruy. And I think in the resources part of my slides, there's a direct link to her website. So post-traumatic slave syndrome is really a theory that explains the etiology or the source of many of the adaptive survival behaviors of African American communities throughout the US. And we could tie this to the slavery for 300 years, the slavery experience. And really here, you could see here the intergenerational transmission of like trauma. So Dr. Joy DeGruy often talks about like a story of hers wherein there are two moms who are talking about their sons. One mom is white and then the other mom is like Black or African American. And then both of their sons are really doing well in school. And the white mom, when the Black mom asked her, oh yeah, your son is really coming along and doing well. And the white mom just went on and on like praising her son. And then when it was time for the white mom to ask about the black son or the African American son, oh no, your son is doing well too. And then the black mom suddenly like talks about, oh no, he's a handful actually. He gets into my nerves all the time. And really that response is adaptive because it brings it back to the experience of like slavery, of during those times, like moms and even like dads tend to denigrate or belittle the competencies or the abilities of their children for fear of being sold as slaves. So you could see there the intergenerational transmission of trauma. And really for Dr. Joy DeGruy, the way to heal this is not only through clinical work, but through social activism and social justice advocacy. It needs a combination of both. I would really refer you to look for the work of Dr. Joy DeGruy in terms of this.
Wonderful. Thank you. Thank you, Dr. Ritchie. Maria, there were so many questions that came up about the community kiosks. Folks are interested in learning, what are they? Where are they? Can you speak a little bit more about these kiosks?
Yes, of course. I thought that was going to generate a lot of curiosity in people. So the kiosks that we have created so far, they have a computer and a telephone, and of course they're being sanitized after the client leaves. And they also have documents where we're explaining clients how to use this technology. So if there's a client that is not comfortable using the computer, they could use the phone, right? Really giving different options to our clients. And the idea, like I said, is to increase the number of kiosks because not everyone is feeling comfortable using their own phones even, right? There could be some paranoia around having my therapist know my phone number or my location. So it's really a good opportunity to bring more clients in the door and really provide more services. And I also, if I have a couple of seconds, I want to share something to add to the response that Dr. Gloria MORROW shared. And I think it's important that we add, like she said, that we continue to reflect on what culture means, right? Because we often associate culture with just race and an origin, but culture means a lot more, right? Like Dr. Gloria said, it's where we live, what we do, what we like. So in the exploring of culture, let's really identify what it is for us. It's not just where we come from.
Excellent.
I totally
Excellent.
agree with that.
This is, let me see, all of you would speak wonderfully to this. Dr. Gloria, I'm going to give this one to you. Should clinicians bring up the topic of racism with our patients or just be willing to discuss it if they bring it up?
Just be willing to discuss it if they bring it up. Sometimes they don't want to talk about it. And so you've got to understand that there is this whole racism related fatigue that people have. They don't want to keep, these are those acute racism reactions, and racism related fatigue and frustration are some of those reactions. And because, people of color are often asked to be the educator for people who are well-meaning, who want to understand more, they get tired. And so that happens sometimes with our clients. They don't want to talk about it. It's too painful. And just tired of trying to explain to people what their experiences are. So what I would do though is provide a healthy environment so that those conversations can exist. And the one thing that I open up with is, with everything going on with COVID-19, with, watching the protests and everything, how are you managing? And that just opens up the door for people to be able to talk about what they really need to talk about so they can feel better when they leave that day. So be willing to do that. You've got to really look at yourself if you're not comfortable with discussing racism. And a lot of times therapists are afraid that it's going to be this big can of worms that's going to lead to a big fallout if we have this discussion. So it's important for you to find your own safe place in discussing that and being willing to discuss it if the patient client is ready to discuss it.
Excellent. I just want to let you guys know we have a lot of more positive comments coming into the question box right now. So I think this is a topic people really needed to hear more about. Maria, I'm going to check in with you. We had probably 3 or 4, maybe 5 comments that came in from people that they found the term Latinx offensive. If you were working with a client, like how do you work around how you refer to an individual and kind of checking in to find out what is it that they want to be called?
That's a great question, and I would say is by asking them. The only way that we know how a client wants to be referred is by asking them their names, asking them their gender pronouns, how they want to be referred, because we cannot assume. And that's the best way, really asking people. And I get also the controversy around the term Latinx. As a Latina, I can tell you when it started, I had also a lot of thoughts about it and how we use it in our language in Spanish specifically. However, I do want to acknowledge that this is a term that we're using mostly in this country and started in this country, right? And it's a term that is more inclusive. And we need, our language really, really matters. And we need to be more inclusive of everyone.
Great response. Thank you for addressing that. I'm going to have the final question, and this one has to do with teams. And Dr. Gloria, why don't you start, and then if Maria or Dr. Ritchie, if you have answers, then we'll hear from you too. What suggestions would you have for engaging other clinicians in the team approach that was advocated? Professionals are also struggling to adjust, and resilience seems to be at a premium. On a peer-to-peer basis, any suggestions for opening the conversation about the need to consider our own learning process?
I think it's such a critical time for us to pull together and to see strength in numbers and to understand that we all hold pieces to each other's puzzle. And like I've been on this team, we've had a couple of times to meet, and I've learned so much from being on this team that we have put together. And so I know the beauty of it. And I think one thing that happens to providers, you can easily become isolated, and you don't know what you don't know. So it's important to be open, to make yourself available, to say, is there anybody out here who's struggling with telehealth? I am also someone who could benefit from, partnering together to get suggestions, to work together for the good of the patients that we serve. And especially if you're in a clinic setting, make sure you're taking advantage of that time. It's really important. We are not the experts, by the way. I know we have gone to school and we have higher degrees. It's wonderful, but we really are not the experts. The experts are those people we serve who have managed to stay alive with horrible adversity and trauma and pain. And so those are the experts. And then when we come into our clinical setting, we can use all of our lived experiences and our professional experiences to help one another to provide excellent care.
And I would just, thanks, Dr. Gloria. And also I would add to that in terms of teams, it's much needed right now. We can be physically distanced, but we don't have to be socially distanced.
Right.
And if we have the virtual platform, it doesn't have to be like a 50-minute meeting. It could just be like brief huddles to check in on each other, Like last week or a couple of weeks ago, we had like a wellness activity of a drumming circle. And that was really healing, just to have something where you don't necessarily have to talk, but have some activity together wherein as a team you would engage in it. I think it's very empowering, especially at this time.
Yes.
I agree. I would like to share something that we have implemented in BHRS. Our director, Jay Africa, started this folder through Outlooks, which is, we call it the BHRS Positivity Folder. And every week we send a question to our team. So share things, for example, what brings you joy, right? Or what has been your favorite food to cook during this pandemic? Or what is your book? Really bringing out our strengths that we tend to forget during these challenging times, and we all are so burned out, but really kind of reminding us of the things that keep us going, which is really important. And that I've noticed that really having that activity has been helpful for the team also to get to know each other, right? I've learned things about team members that I hadn't before, and because it's so big that I haven't even met certain people. So it's really bringing people together by just asking a simple question as, what have you done for your mental health this week, right?
Mhm. It's
I
great.
would just add
Wonderful.
one thing
Great.
in terms of telehealth, like having teams is a great opportunity to practice like telehealth. Like if you're not sure, how do I share screen? You know, you can practice with your peers before you
Yes.
even try it with a client. I think it's a wonderful opportunity to do it that way.
Mhm.
Wonderful. Thank you all so much. We are at the end of our time. Again, this was a fantastic presentation, and we will do some planning after this, everybody who is participating, because we know that we need to be able to stay with this topic and go deeper into it. And I do want to especially thank the California Healthcare Foundation. They've sponsored this entire webinar series, and just so appreciate their generosity. And thank you, of course, to all of you for attending.